Evaluation of different bracket systems on external apical root resorption. And again, you can see a lot of papers have come out recently, probably in the last 10 years, where up until, again, 1999, they weren't there until we did our paper, and I'll show you that shortly. Treatment duration, we talked about that. The longer they're undergoing orthodontic tooth movement, the greater incidence of resorption. Increase with increased treatment. During orthodontic treatment, influenced by age and gender, they found. No difference between self-ligating and conventional brackets, which we already addressed when another study demonstrated that. And these are the things I talked about back in December about the aspect we all have surface resorption. We all have maybe some inflammatory resorption. This is going to happen, and these can be occurring before the orthodontic treatment is done, but it's very, very difficult to tell because the only things you are going to see are going to be the proximal surfaces of these roots. You cannot see the buccal nor the palatal surfaces or lingual surfaces of any of these roots prior to orthodontic tooth movement. Now, we know that in order to see any type of resorptive process on the buccal or palatal surface, up to 40% of the root must exhibit some type of resorption. It's called the loss of mineral per unit volume that Bender and Andresen pointed out a number of years ago. And until you get that loss of that mineral per unit volume, you're going to look at a radiograph and say, that tooth's fine. I don't see any resorption. It very well could have resorptive processes going on. Now, if the movement of the teeth is done in a gentle way and not too aggressive and not over long periods of time, chances are those areas will repair. If not, then we get into areas where this type of thing can occur over time, and one can potentially lose the tooth completely. The surface resorption can be any depth, but if you notice in every one of these, and by the way, everyone who's on board for this seminar is actually, you probably have teeth in your mouth that are undergoing some type of surface resorption. And as long as you have this repair going on, you can see the repair that's going on in every one of these areas, even though the resorption has gone into the den. As long as there's repair, it's not going to be a problem. And you're going to be back to normal. You're going to have a fully functional tooth, and it's not going to undergo any type of ankylosis. However, if you get involved with replacement resorption, that's when you get bone moving into the tooth structure, as you see the haversion systems here, moving into the tooth structure. Then you've got problems. You're never going to move that tooth any farther, and you're going to have all kinds of difficulties. And that's one of the important things about monitoring cases that are undergoing orthodontic tooth movement. And if you lose a patient, for example, if they move or they don't respond to recall evaluations and things like that, these kinds of things can happen. And now you have to struggle. Here's a case that was done orthodontically. The teeth removed. Multiple problems with this case. Number one, the teeth were moved and they weren't necessarily brought into full alignment. Okay. Number two, there was no retainer put in. Number three, the teeth were moved by two different orthodontists over a long period of time. There's like 3 years, 3.5 years. Okay. Number four, the patient was not very diligent in their oral hygiene. Now, when you look at these factors, and all of a sudden, out of the clear blue sky, the patient says, doc, I've had some orthodontic tooth movement, and I've had some tooth discomfort, and I'm having a hard time keeping these areas clean. And the orthodont or the general dentist sends me this case and says, please do an evaluation of these teeth. And this is what I have to deal with. This is what happens over time when these patients are not followed up and attention is not paid to them, and there's poor oral hygiene, which contributes. Look at the bone loss. Look at the plaque, the calculus buildup on these teeth, and look at the resorption that's occurring. And every one of them. In fact, if you look at this tooth right here, this canine, if you look at the apex is open. Why is the apex open? Here's the canine. Look at the resorptive process that's actually digging into the tooth with this apical resorption that has occurred. This is what can happen if you don't pay attention to these teeth that are orthodontically moved. That's why You got to have a baseline to start with. You got to follow them up, and you got to really be careful to make sure that there's no changes. Otherwise, you end up with this situation. This patient lost all 6 anterior teeth, and implants, 4 implants replaced. But you can see the potential problems that occur. External apical root resorption is usually due to heavy, intrusive, or tipping forces. That the literature is very clear on that. Heavy, intrusive, or tipping forces, yes. Teeth with blunt or pipette-shaped roots are at greater risk for resorption. We see that a lot in premolars. Teeth with vital pulps tend to exhibit resorption prior to teeth with previous root canal procedures, as long as the root canal procedures are done properly. If they're not done properly, I'll guarantee, and I've seen this, that the root canal treated tooth will show resorption much more rapidly than the vital pulp, tooth with a vital pulp. Teeth with degenerating or necrotic pulps are at greater risk for apical resorption during tooth movement. That's why you have to evaluate these teeth ahead of time. Now, how do I know I've got a degenerating pulp? I went through, I took my electric pulp tester, everything responded normally. I put cold on the teeth, they responded normally, or at least within an acceptable range. Now, how do I know I have a degenerating pulp? Well, take a look at the pulpal space. Is the pulpal space in that tooth diminished? Are there large restorations in that tooth? Are the pulp canal small and narrow compared to other teeth, compared to the contralateral tooth? Is there a potential presence of pulp stones in the chamber of the tooth? Is there the presence of chronic focal sclerosing osteitis at the end of the roots? In other words, an increase in bone. These are all indicative of a chronic pulpal inflammation or degeneration. These are the kinds of teeth you really need to jump in and do your root canal procedures before bonding them and running them through orthodontic tooth movement. Now, here's a case, just to give you some idea. The 2 central incisors were the same length, and the lateral incisors were at almost the same length. But guess what? Apical resorption during the tooth movement occurred on the 3 teeth that did not have the root canal treatment, and the 1 tooth that had the root canal treatment maintained its apical status. Yet, at the same time, other teeth will, if you don't follow through, you're going to find these teeth possibly undergoing necrosis. Take a look at the calcification that's built up in this pulpal space, necrotic pulp. Take a look at this wide open apex. You have apical resorption and a narrowing, and you actually have calcifications running down the canal right here. This creates a real problem now if you want to do this and manage this endodontically, because that's what the apex looks like, and those are tough to deal with. You're going to end up having to alter your whole endodontic technique, your whole technique of root canal procedure to be able to manage that. And it can be done, but you have to understand the nature of the beast that's happened with this apical resorptive process. The idea is to catch it ahead of time or prevent it. Let's ask some questions. If root-filled teeth are subject to resorption during orthodontic tooth movement, what will happen to the filling material? That's question 1. Keep that in mind. Write that down. We're going to come back with the answers. Question number 2. If resorption does occur, what will happen to the apical seal? Will this result in failure of the root canal procedure? Good question. Question number 3. If resorption does occur, especially during more radical tooth movements, such as rotation or intrusion, can it heal? These are all good questions. Let's try to answer those. Now, keep them in mind. We'll take them one by one. Answer to question 1. Tooth may resorb, may exfoliate, root canal filling material comes out with the tooth, and that's it. No big deal. It's not a major hassle. I've had it happen. I've actually been able to pull that gutta percha out after a tooth underwent resorption over a period of time. And this usually occurs after having a poorly done root canal treatment, and the patient has lost track of after they had the orthodontics. No one's ever followed up on them. They come back and say, I haven't been to the dentist in 10 years. You take a look at the tooth, and this is what you find. Material does not come out. It's got a fibrous encapsulation, inflammation. You may have to do surgical removal, which I've done before too. While rare, the gutta percha may resorb. Now, some people think, and they tell people that gutta percha is an inert material. Let me tell you, ladies and gentlemen, it is not. It can undergo resorption. I have SEM pictures showing gutta-percha cones actually undergoing resorption. Resorption may begin, then stop with the material sticking out of the apex and a new periodontal ligament forms. Now keep that in mind. You may look at a tooth and say, oh my gosh, Mrs. Jones, look at this tooth. You've lost some of the root structure and the filling material sticking out the end of the root, but there's no lesion. There's a normal periodontal ligament. Leave it alone. Don't do anything. Don't mess with it. It's that old adage, don't kick a sleeping dog. Those are fine. If that new periodontal ligament forms, what that means is that that canal is sealed at that point. It's sealed and everybody's happy, and you leave it alone. Don't do anything. A resorption may begin, then stop with the material sticking out. Then a lesion develops. Then you got a sinus tract, swelling, and the patient may have symptoms or may be symptom-free. That's the time you have to intervene. And more often than not, on these types of cases, you may have to go in surgically. But you can still actually try it non-surgically first. I think that's very reasonable. And each case will be somewhat different. Each case will be somewhat different. Typical what you find in a lot of these things, not uncommon. Answer to question number 2. Okay, if you've done good cleaning, shaping, disinfection, and obturation are well done, the apical seal should not be affected by your orthodontic tooth movement. If there's resorption, it should not affect it at all. The coronal seal could be challenged, however, if you've got coronal problems where you have a poor restoration in the tooth, or, and let me throw this out to you also, keep in mind that every tooth in the patient's mouth, your mouth, my mouth, everyone's mouth, there's a certain percentage of the enamel cemental junction which is not complete. It's not a butt joint. In other words, there's exposed tubules in the cemental enamel junction area. And because of that, because of having those open tubules, patient develops periodontal disease, you could have rampant movement of bacteria in through those tubules into even a well-filled root canal. And if you're undergoing orthodontic tooth movement, all of a sudden you get this rapid resorptive process. Why? Because you've got bacteria coming into the tooth through that root canal filling and right on down up to the apical area. Keep that in mind as a possibility. Exposure of tubule, there it is, smear layer, retained debris may enhance resorption if it wasn't cleaned properly. There may be evidence of root filling material protruding out the root apex with a normal periodontal ligament and bone and a symptom-free patient. That's very possible. Leave it alone. If it's all done well, no big deal. You know, sometimes you get to do these kinds of cases, you move the teeth, everything is sealed properly, everything heals properly, and it's not going to be a hassle. Answer to question number 3. Cemental repair can occur after rotational tooth movement. Yes, it can. In other words, if we've got the intrusive or the rotational, where it's a greater amount of forces being applied, will you get repair later? Yes, a repair can definitely occur. It appears that the non-collagenous matrix protein osteopontin plays a role in both resorbing and repairing those areas, as long as there's no bacterial influence. If you have periodontal disease, bacterial influence, you've got problems. It's not going to repair. Intrusive forces are the most damaging, with evidence of degeneration, vascular components, and the extracellular matrix of cementum and periodontal ligament. With the most severe changes apically, you have to decrease the continuous forces, recommended, and you have increased time plus increased force is going to be increased damage. And therefore, you're going to have significant resorptive cratering on the tooth. And remember, what you see in a periapical radiograph may be nowhere near the damage that's done on the buccal or the lingual or palatal surfaces of these teeth.